Welcome everyone to today's program. I'm Molly Gamble, Editor-in-Chief of Becker's Hospital Review. The program will begin with a presentation and we will have a question and answer session following completion of the presentation. You can submit any questions you have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during the time we have and will follow up on questions they do not have the opportunity to address. You'll receive an email within about a week following the webinar that will include instructions for how you can download a copy of the presentation. You will also receive a follow-up email shortly after completion of the program. You can submit your feedback or any additional questions at that time. This email will not include the presentation. It is now my pleasure to introduce today's presenters. Bill Egbier is the Managing Director of BDC Advisors. Mr. Egbier is a frequent conference speaker and author on healthcare topics and received the 2013-2014 Helen Yerger L. Van Sewell Best Article of the Year Award from the Hospital Financial Management Association for its feature article called Partnering with Payers, Key Lessons to Keep in Mind, which was published in the January 2014 issue of HFM magazine. Mr. Egbier has led numerous successful health plan strategy engagements for a number of the nation's most influential healthcare systems and academic medical centers. Jackie Macias is a Senior Advisor to BDC Advisors. With more than 16 years of executive experience, Jackie's expertise includes a track record as a senior executive driving top-line revenue growth and improving engagement and health outcomes for Medicaid, commercial, and ancillary products. She has a deep understanding of strategic planning and execution for the health plan industry, with a keen focus on finance development, organization design, integration planning, and implementation while gauging external market conditions, assessing internal assets, and designing strategies to differentiate clients while delivering membership and revenue growth. It is now my pleasure to turn the floor over to Bill to begin today's presentation.
Thanks very much, Molly. This is Bill Egbier, delighted to be here with you this morning or afternoon, depending on where you're tuning in from. Our discussion is going to focus over the next hour kind of around the intersection of three current ideas in healthcare. Population health, the notion of creating healthcare delivery and financing vehicles that in turn create accountability for value across defined populations. The retail market, the new healthcare purchasing landscape in which consumers are exercising choice in their selection of both health plans and individual health and wellness services. And finally, value-based contracting, which is really in the center of the bullseye of the talk this morning, which is the creation of relationships between providers and payers that are focused on value, not just payment of fees for services. We could move to the second slide, please. I'm sorry, let's be on the objective slide. Slide 2. Our agenda this morning, we're going to talk about first the goals of effective value-based contracting, the pros and cons of different kinds of arrangements between providers and payers, what's required to make the transition from a traditional fee-for-service contract to a value-based contract, some of the factors that influence a successful implementation of a value-based contract, how to think about risk for your organization and how it relates to specific contract terms, and incorporating the right kinds of safeguards to mitigate the risk that you're taking on in these forms of contracts. I'm going to lead off with discussion principally around the goals for effective value-based contracting, and then Jackie's going to take it from there and get into another level of detail. So if we could have the next slide, please. The value discussion in healthcare began really with the IHI's triple aim concept. And just a reminder, improving patient experience of care, both in terms of quality and satisfaction, improving the health of not just individuals but populations, and reducing the per capita cost of health care, which of course means providing care more efficiently to individuals and across populations. This way of thinking requires a focus on longitudinal performance, not just a single instance of care. And I say instance as differentiated from the episode, which can indeed have a longitudinal aspect, and which we can get into as we think about bundles, which can very much be a value-based contracting model. Next slide, please. Value-based contracting is differentiated from fee-for-service contracting in a lot of ways. It usually starts, of course, with a base contract defining the terms of payment. Terms might be expressed as fees for services provided, as they are in traditional fee-for-service contracts, or they might adopt a whole other payment methodology, like capitation or a global budget. But the basic framework is the core of the contract. And then wrapped around that core are a whole set of other considerations that really make this a completely different animal. To think about the design of the product being contemplated in the contract, what's the target market, what are the range of services that are going to be provided to that target. Are the services going to be delivered through an open access network or through a narrow network or a multi-tiered network? What kind of exclusivity is involved, both from a provider's perspective and a payer perspective? What kind of performance metrics are we going to measure? Cost of care metrics, quality metrics, access metrics. How are those metrics measured? How are they going to be reported back to the providers in the network? How are members or patients attributed to the contract, particularly when they're not directly receiving reimbursed services, if they have to be part of a target population but aren't actually receiving services yet? Who's at risk in the contract? Is it how much risk does the payer bear? How much does the provider system bear? How much risk gets pushed down to members of the provider network? What's the scope of the contract? Does it cover hospital services only? Does it include physicians? Does it include subacute providers or other ancillary providers? What's the nature of the performance incentives contemplated in the contract? Is it shared savings? Are they quality gates that are set up the potential for shared savings? Are they bonus payments based on the achievement of certain metrics? Is it just a simple retention of premium by the provider system if the cost of care is below what was targeted? And all these terms have to be thought about and covered in the contract in a way that protects the provider as well as the payer. Next slide, please. The key element of a value-based contract is reducing cost. And that happens in a variety of ways, through lower unit of service reimbursement or price concessions on the part of the provider, or through eliminating unnecessary utilization and or providing care at a lower cost, more appropriate level of the delivery system. The net impact of these varying focuses on value is almost always going to be less realized revenue for the delivery system. And this kind of contract only makes sense if a delivery system can reduce its underlying cost structure for providing services, or if it can gain market share through increased access through a broader network or through increasing its preference among consumers. And so consumers turn to the provider system through this contract more readily. Next page, please. The provider is looking for a sweet spot in these arrangements. If the provider is not effective in managing care, meaning that its cost per unit of services are too high, or if it provides too much care, or if its quality performance is such that it doesn't earn designated incentive payments, then in the end costs exceed payments and the contract is not a success from the provider standpoint. On the other hand, if the provider is too effective at reducing costs, invests in improvement in access and quality, and doesn't have a mechanism in the contract to capture that value created, doesn't have enough at risk, then the value accrues to the payer or to the payer's customer, an ASO employer, for example, and the provider system loses. And so we're looking for that sweet spot in the middle in which we anticipate what we can accomplish from a care delivery standpoint, try to price it correctly, and then have an appropriate amount of risk that enables us to capture value created. Next slide, please. This slide describes a whole range of risk-sharing or value-focused contracting arrangements. And we just parenthetically, we tend to think of risk-sharing and value-focused contracting as being two sides of the same coin. You really can't price for value unless you're taking some level of risk, and so I tend to use those terms interchangeably. But in this chart, we're looking in the vertical axis at a variety of kind of forms of payment for episodes of care, payment for performance, a P for P, focus on particularly diseases or conditions, or focus at the population level where we're defining a population that we're going to cover. And then there are, on the horizontal axis, a range of services that might be bundled into such a contract, from a very narrow acute care DRG, for example, single episode of care around a very specific focus, to a full, broad global capitation arrangement at the upper right-hand quadrant, and all kinds of things in between. Typically, the value-based contracts that we see are focused in a kind of subset of these possibilities, the ones that are indicated by the red circles. But we're also seeing more and more creative contracting initiatives, particularly as people focus on categories of population customer segments, for example, specific chronic illnesses, ESRD, for example, or focus on specific categories or episodes of care, such as certain orthopedic procedures or normal deliveries, or even certain cancer treatment protocols. And that kind of specificity often requires a more creative contract structure. Next slide, please. This chart really helps us think about that there are multiple potential elements in a contract, where it's being positioned in the market, public exchange, for example, versus private exchange, the shape of the network, what's the nature of the pricing, how does it incorporate transparency requirements, what kind of network affiliations are built in. And those elements have a variety of impacts. In the center of the chart, we're looking at their potential timing of the impact. It's something we're likely to see in the short term or as a longer term, and how will it be expected to play out in terms of its impact on the provider system. Is it primarily about volume impact, or is it going to affect reimbursement, unit cost in some way? And all of these elements need thoughtful design and careful planning, or the net result on the provider system revenue can be negative, of course. So with that introduction, I'm first going to ask Jackie if she has anything to add on what we've just talked about, and then turn the baton over to her, and she'll take us through the next parts of the presentation. Jackie?
Okay. Thanks, Bill. No, I have nothing to add. This is a great setup for the next part of the presentation. So what we're going to be talking about now is pros and cons of the various arrangements that Bill had highlighted. Not all of them, but specifically on a few. So on slide 11, what this illustrates is the continuum of shared risk arrangements, and I define them as emergent. On clearly one end of the spectrum is your traditional fee-for-service, where one gets paid for every unit of service delivered without any terms related to outcomes or quality or cost, etc. While on the other end of the spectrum is the vertical integration, which actually could have some portion or whole ownership of an actual health plan as an insurer. In between the continuum, the provider delivers various levels of service with specific populations at predetermined price or quality levels. It's important to note on this continuum is that, as Bill clearly indicated, one size does not fit all, but all of the arrangements as you go through the continuum will involve an expansion of downside risk for the cost of care, be it bundling, all-in, capitation, etc. So, but the design here is the risk and rewards and trade-offs, and how you make a decision to enter into any of these relationships or arrangements is to increase the capture of the premium dollar, is to increase the spend to the health system, and we'll talk about in a variety of ways you can do that. So each of the elements on the continuum will be reviewed on the next several slides. So slide 12, please. Okay. The pay for performance is the most popular contract today, where bonuses are paid or a portion of payment is withheld, based on whether we're meeting the performance targets related to cost effectiveness, efficiency, or et cetera. There are pros and cons, probably more pros to this arrangement than others. First and foremost, it's a good starting point to start deeper engagements between the provider and the payer, especially given the traditional, how each party view creating value. Secondly, it does provide additional revenue that the providers might not normally see in other cases, which could help for investment purposes. You can do it with any level of membership. It's quick to implement with contracting terms, and risk is usually only to the upside. Cons in this type of arrangement: uncertainty will exist, related to whether the provider can actually accomplish the goals, and that's why, or the metrics, whatever, that's why picking the right measure is critically important, or payment will not be made. The second con, and actually you will find that this will be a challenge through all of these types of arrangements, data sharing between the parties involved is critically important, from claims to electronic medical record information, to analytic data, et cetera. And payers have traditionally have a volume of very valuable data, but it sometimes is in multiple systems, requires multiple processes to validate it, confirm it, and reporting on it. And this is improving. We're finding, I think now we're up to probably 16 or 18 states where payers have come together to create one claims sort of depository. So this is improving, but it's still a challenge, especially depending on how large or small or regional or local or national the payer is. Finally, this, when we're trying to move the needle on cost of care, there's this will lower some of the costs, but may not have a significant impact on the overall cost of healthcare. So it's somewhat effective, but limited in the sense that the incentive has to be big enough. It has to be a larger patient panel for it to really make an impact on cost. Also, it should be noted, as Bill also addressed, that this type of arrangement can be made in conjunction with other payment models, fee-for-service, bundling, capitation, et cetera. Okay, next slide, 13. Okay, the shared savings contract or gain share. What happens here as performance improves, financial gains are shared, and basically there's incentives to reduce the spend for the population. Normally, these arrangements have about 5 to 10 measures that are measured in a ladder approach with thresholds, 20, 50, 75%. For the quality metrics, and examples of efficiency metrics include bed days, readmission, generic prescribing, et cetera. In these arrangements, it definitely aligns incentives for providers to reduce the cost of care, again, having a percentage of the savings shared. There's protection, for the providers. It also allows the providers, be it primary care or incentivists, et cetera, to really control the member experience, or what I refer to as engagement, more. You're going to be closer connected, to that member as you provide the care. And in this instance, it's also attractive to payers because sharing in the savings, they're going to share in something that they, normally would not see without this arrangement. Some of the cons are, again, payers do not have to do much or make much of an investment to get half of that benefit if it's a 50-50, for instance, split on that. We already discussed the payer data and reporting capabilities. In this instance, however, for shared savings, the information and the timing of the reconciliation of the information is usually is always after the performance period, and there may be a lot of back and forth that happens for, if there's reporting differences between payer and system, et cetera. And so the revenue that will be generated is kind of seen well after the performance period in some cases. There's also a notion of diminishing returns in this type of arrangement over time. The better you get at it, the better you get. So it becomes challenging to determine how to get any more savings after you've reached your targets. And so what you need to do is really try and find additional measures, innovative ways, other ways to save costs that can eventually be shared. Again, this is more effective at engaging providers more so than the pay for performance, and can be coupled with fee-for-service bundling or capitation. It's important to note at this juncture that both pay for performance and shared savings, again, can be used in conjunction with those other contracting mechanisms, but bundling especially should have some additional considerations, as bundling provides one fee for an episode of care. Therefore, the provider or the system entering into the arrangement may have to contract with other providers in order to administrate that. And so that should be a careful consideration when you're looking at other types of contracting arrangements in conjunction with these types of contracts. Next slide. Okay, so here we have the capitation. This is where the provider administers a contract and assumes risk for defined services. This could be via PMPM or, in some instances, a percentage of premium that patients pay. Unlike the bundle payment, where you may or may not need to contract with downstream providers, such as home health, etc., here you do. I mean, it's necessary to have control of the downstream contracts as you're trying to manage a capped fee, in the process. And so some of the pros or some of the advantages of this is, of course, you get upside risk. So if you're paid a capitation rate and you spend less, you keep it. It also improves cost predictability. So as the system and the provider enters in some of these arrangements, reserve setting and other actuarial disciplines need to be enhanced. So cost predictability becomes very, very important for reserve setting, as well as pricing of the services. And so this will actually give more exposure to that level of detail. Of course, it improves the provider-payer engagement and even provides more member engagement that the provider can have more control over. So some of the downside, well, there's definitely downside risk for the providers in cases where the capitation is less than what the actual cost of the services are. And again, some of the other disadvantages are the reporting capabilities and the timing of reconciliation, and high membership threshold, which means the larger the volume helps to distribute some of the risks in these arrangements. So the more volume in these arrangements, the better. Okay, slide 15, please. Okay, so in this arrangement, which is actually a joint product development activity between payer and provider, the advantages of this basically can be summed up in that it's the provider not going it alone. Okay, so not trying to enter, a market with a new product or an insured product on their own. It also will provide capital investment in infrastructure because the payer comes along with that infrastructure and a very well established, in most instances, a platform. And of course, the payer will come along with a recognized brand in most cases. So again, the advantages are not going it alone. Some of the downside risks to providers in explaining to get the competitively price the product that's most effective to move membership away from competitors of both the payer and the provider. There are many levers to be considered. And as Bill alluded to, there's consideration of volume, there's consideration of unit cost changes, there's consideration of utilization and other shared savings. There's also consideration of, again, we addressed the brand, but also the type of network. So the downside risk to the provider comes in the form of not meeting volume expectations, and we'll talk a little bit about that, not meeting the efficiency and quality metrics that are proposed in the arrangement. And of course, if unit cost changes to a level of a concession that do not cover the cost, those are all downside risks to the provider. So speaking specifically on the volume growth, volume is usually composed of actual increased membership, new membership in, and then steerage, which is steering current members in another product to the new product that's being developed. And the caution here is specifically defining new versus existing members, because it's one thing to move patients that are currently within the health system to a lower product payment structure, but another to move patients that the system never had before, which are the new patients into the system. So a careful analysis has to be done with regard to that steerage or shift and the composition of that for the health system. So next slide, on slide 16, this talks a little bit more about private label products, and essentially shows that you can have different products that have different complexity and also increased risk. So products like the employee health plan, direct-to-employer, Medicaid, Medicare, will not have as much savings driven by the providers, but are easier to deal with on the risk side of the equation for the provider. When you get into the individual exchange and small group and commercial products, this is an area where the payer is likely to require unit cost concessions and be very considerate of their own margins to make sure the product is priced correctly, but also that everybody has benefits of the product arrangement. Bill, did you have anything else to share on this slide?
Sorry, I was muted. Keep going, Jackie. That sounds good.
Okay, perfect. Okay, so on slide, let's move to slide 17. So what we're going to talk about now is what's required to make this transition from fee-for-service to some spectrum of the risk contract. And it really evolves around superior care management, physician alignment, new forms of financial management, and enhanced consumer experience, really taking in that full spectrum of what's happening in value-based contracting, consumerism, at the forefront, and the triple bottom line, at the triple aim. And so the scope, capabilities, and environments need to be broadened to be successful with population management, with the goal of maximizing wellness and minimizing illness, essentially. Also, population management really requires an integrated delivery access, through all life stages. And this is where alignment with the physician and providing physicians with the infrastructure, technology, tools, defining the network, it really has to all be aligned for all of the systems, through primary care, through specialists, et cetera. And this physician alignment, can really be experienced through having a good governance process, having the physicians part and play key roles within the design of these arrangements. And having having a voice on developing all the elements, of the arrangement. Actuarial expertise and is going to be very important for health systems to have segmented analytics, predictive modeling, expertise in contracting. The most important, item here is to really understand the current costs of current services and of any downstream partners that the health system would have. Without understanding this, there could be a real risk of over or underpricing things like a bundled arrangement. So the proficiency of financial management, is essential. And finally, enhanced consumer experience. And again, as Bill alluded to, that as we transition to a real consumerism model where people will be making more decisions about their care, really understanding the importance of that model is important to have the right skills. On slide 18, we have some successful implementation factors here. So these arrangements really require a top-down view of risk and management, buy-in and commitment across all levels of the organization, because what's happening is it's really a change of culture or mindset. So the cultural or mindset change is really, the way I look at it, or the way we look at it, is utilization is an expense, not a revenue anymore, as you move along this spectrum. So it's really important to build a culture around that mindset. We talked a little bit about clinical integration of physicians that must be solid, but the physician and hospital objectives must be clearly aligned. There should be an investment in the primary care physician, be it employed or contracted. As you transition from fee-for-service to value-based, they're sometimes seen as a takeaway in the primary care physician spectrum. So again, having board involvement, key positions, key roles played by physicians is definitely a will factor into success. We've already talked about identifying and managing the right metrics and of course the importance of really granular data analytics. It's important for the provider and payer dialogue to focus on engagement and really have shared goals and incentives, and have a dialogue that encourages those that have the most control should be making most of the decisions. So, focusing on rate change or whatnot should be more of an output of what the payer and provider are trying to accomplish with regard to population management and moving the needle forward on the quality and cost of care. Being the first mover really, or fast follower, depends on the current market position and financial strength. So determining, when, with whom, and how to start population management and assume risk are critical. And also determining what the current capabilities are and the financial capabilities for investment, et cetera, are important. And of course, where both the payer and provider, how much market strength and market position they are in to be able to, increase volume and steer members away from the competitors should be an important consideration. And finally, capital to build networks, technology, care management infrastructure, and maintain reserves, of course. Having access to capital really also helps in the implementation of these types of arrangements.
Jackie, I wonder if I could jump in with a couple of thoughts here. There's some real critical strategic considerations as you think about this. And one question is always kind of how far and how fast do we move? Life has been pretty good under fee-for-service contracts. We're doing well as a system. How much risk do we create for ourselves? How much do we threaten the success that we've experienced under a fee-for-service environment in moving to a value-based model? And you really have to answer that in the context of how fast you think the market around you is moving. It's really hard to change the culture with small steps. You got to get enough at stake to get people's attention and to be able to change the way that you operate the system, and that argues for going broader and deeper. If you think you're in a market that could change quickly, the imperative for doing that is of course much higher. A lot of people, as they think about potential value-based contracting initiatives, the immediate opportunities we see are, particularly with employee health plans, you're already at risk for your employees. Most provider systems have some sort of employee health plan, and most really do not think about their employee base as a population that they want to actively manage. They have a TPA. TPA provides services, may or may not provide useful information in management. And by thinking about your employee base as a population and thinking about how to manage that population more effectively is a great way to start with minimal risk to the organization. The other place people are beginning to work is with Mssp and Medicare, a relatively low risk, upside only at the moment, way to focus on accountable care initiatives in a way that affects really only a population that you're not achieving break-even reimbursement on a fee-for-service basis anyway in most cases. And others are taking an even bigger step into Medicare Advantage, which again you can engage in without affecting commercial contracts that may be quite attractive on a straight fee-for-service basis. Go ahead from there, Jackie.
Okay, perfect. Thanks, Bill. On slide 19, so in defining risk for the organization, I think that to understand how traditionally value's been created for provider and payer, we're provider, focused on pricing, asset employment, patient mix, and procedure, and the payer is around reimbursement rates, utilization rates, and product design can be viewed as a conflict, and we're finding that this conflict is being overcome as payer and providers partner in these types of arrangements. Understanding that conflict, understanding the need for differentiating value proposition and innovation to gain a better position or an enhanced position in the marketplace, and understanding the cost of what it's going to take to get there are all things that should be considered when evaluating the risk. We look at risk I call it the 2 E's, basically risk of execution and risk of estimation. Execution being that the risk, the need to have a robust infrastructure, downstream contracts, using capitation, having governance models, and all the management around that, the data analytics, the IT, et cetera, is really operational risks that must be considered when you're looking at where am I today versus where do I need to be in the future, and where am I today? Where does that best fit in which arrangements best fits my current position, but will allow me to evolve to a more of a risk-taking arrangement. The second risk is estimation, and what I mean here is really actuarial risk. So rates and costs for defined populations, being able to very agilely identify where costs and prices are inaccurate and make corrections through initiatives, the ability to reserve properly now that there's more skin in the game and risk. And the process of going through evaluating execution and estimation risk is really an iterative process, because as Bill described, there are many elements to these arrangements that have to be considered individually and of themselves, but then also in a very holistic view way in order to develop pro formas, et cetera. Important here too is also defining, and when we're looking at that actuarial or estimation risk, who exactly is covered, what are the gaps, are physicians employed or contracted, what services are there, that all have to feed into that assessment of rates and pricing and cost. The key message is that pricing and payment must be competitive in the market in order for both payer and provider to win in the marketplace and move their market position. So again, some more successful implementation factors is value-based contracting is should be considered by healthcare organizations as non-participation in some of these arrangements. May not get the healthcare system where they need to be in the future, and a little bit of a leave behind. And it's important to know or to understand how you can really cap some of the risks for both parties as you're going into these arrangements. What's important is focusing on the right service or product. Given the resources that everyone has, which service, who, and how large is the population to effectively manage, given what is there today, and how will that look into the future. Also, we talked about, as we get into some of the more sophisticated arrangements, like the product and the reliance on increased spend at the hospital system due to increased membership and steerage, you do want to incorporate some language or some sort of mechanism that will offset losses if some of those assumptions don't come to fruition. And those mechanisms, there's various mechanisms that can be used within the contracting framework. Avoid relationships and strain of matching discounts, meaning that if some of these arrangements can focus specifically on a population, a product, a narrow, a geography, a geographic area, et cetera, and so cost concessions or any arrangements can be narrowed so that there's not an impact on existing contracts, or if there is, it's in a very controllable, targeted area. We talked about having clear data and analytics, and don't underestimate the time required to move the needle. This is not easy. Sometimes, and even an exploratory year is used between payer and provider in some of these arrangements until they can, find out how to really nail down some of the contracting. And if there is a contract, you just always want to clear out, understand the term of agreement, have sufficient clauses that are protective. Bill, did you have anything to add to that?
Sure. I just wanted to say, there's some very successful, still early, but I would say successful examples of provider system and payer partnerships out there that are kind of founded on the kinds of contracting ideas and principles and strategies that we've been talking about here. And how do you define success? I really think of it as has the provider system been able to move the needle on market share and utilization while giving up revenue on the unit cost or volume per enrolled member. And how do you move that needle? It's a focus. It's a combination of factors. It's what kind of membership volume does your payer partner bring to the table, and what kind of incentives are built into the partnership for that payer partner to move their enrolled membership into your private label product. There's the opportunity to increase steerage for your payer partners' members who aren't in the product, but who are just influenced by the changing, evolving physician practice patterns taking place in your network. What kind of safeguards can you build into the contract to ensure that those volume shifts actually occur, and that you're not simply cannibalizing profitable existing business with unit cost concessions? But if you put the pieces together, it is indeed possible to create a partnership with a payer that benefits the provider system as well as the payer and consumers. So let's that covers the material we wanted to share with you. I think we have a lot of questions queued up. We probably won't get to all of them, but we'll get started. And if the folks at Becker could moderate here, and we'll try to work through what we have.
Absolutely. Thanks, Bill and Jackie. It was a really informative and enjoyable presentation. Like you said, Bill, there have been a lot of questions rolling in, so we have a lot to get to in the time we have left. For attendees listening in, if Bill and Jackie don't have a chance to get to your question, they'll be following up via email with the questions they do not have time to address. And then there will be a copy of the presentation sent to all the registrants in about a week. So that will be on the way. And if you did want to answer questions still, please do so in the space labeled Enter a Question for Staff and clicking Send. So that is still open for questions. So Bill, it looks like this first one is for you. How will providers be able to navigate the increasing personalization of medical treatment with the standardization required to reduce costs under PHM?
That's a great question. Not specifically focused on contracting, but I think more broadly in the strategy of responding to these changes that we're seeing in healthcare. And I think it starts with having the right focus on consumer segmentation. What are the needs of the consumer segment that you're targeting? So just as an illustration, a consumer segment that has multiple chronic illnesses going on, very high cost, high risk patient, can benefit from very intensive personalized care management, one-on-one connection between a care manager and the patient. You obviously can't afford to provide that level of personalization for every member of a population that you might be targeting. And on the other end of the spectrum, provider systems are beginning to experiment with virtual primary care, where patients' interaction with providers in the system is almost exclusively via the telephone, data transmitted from wearable and other devices and through virtual online connections. And so there are no office visits. Obviously, that model of care only works up to a certain point of complexity and the patient's need, but it can be exactly what a patient or a member who has relatively few acute or chronic health needs, it can be exactly what they're looking for. And so you have in one case, almost a depersonalization, although that virtual care can be quite personalized, in contrast with deep care management.
Wonderful. Okay. Thank you. And Jackie, this next one is for you. Although shared savings arrangements enable you to start collaboration with a payer, we haven't seen a financial benefit. Are there $1 shared savings arrangements, meaning you share in the savings as long as the medical loss ratio is lower than the previous time period?
Yes, there can be arrangements where it doesn't, you don't have to wait as long to experience the savings, and you can actually have thresholds where some arrangements are an agreement to a high and a low medical loss ratio, and then taking that differential and sharing if it's above or below that threshold. So there are those types of arrangements as well, not as frequently that I've seen, but there are some first dollar ideas that you can do so that the revenue is generated sooner rather than later.
Okay, great. This next one, Bill, is for you. Pay for performance. We have historically seen this in form of a lump sum payment. Now it seems to be moving toward a tie-in to the year-over-year trend calculation only. The latter is not preferred as we cannot pass along direct incentive payments back to physicians, which hurts provider engagement. What trends are you seeing and what do you recommend?
Just a couple of thoughts here. One, just a global comment that I think pay for performance incentives are sort of diminishing in popularity, that people are really trying to push more towards shared savings contracts because they have more potential to actually move the needle on total medical cost. What we've found is that the best way for provider systems to manage the incentive situation is for a provider systems clinically integrated network to contract with a payer for and to define performance measures and incentives, and that those incentives are then paid in bulk to the clinically integrated network. Can happen on a monthly basis, on a quarterly basis, on an annual basis, depending on what the cycle for the performance measurement and incentive payments are. And then the clinically integrated network in turn pays incentives to providers based on a formula that it develops with its participating providers. So the clinically integrated network becomes the aggregator of incentives, can do so across multiple health plans, and create both a reporting system and an incentive payment system with its participating physicians that keeps people aligned and motivated.
Okay, thanks, Bill. So it looks like we have about under 1 minute left, so we are going to conclude the Q&A portion of the program. Like I said, though, if Bill and Jackie did not have a chance to get to your question, they will be following up with all the questions that rolled in, and then a copy of the presentation will be sent to registrants within about a week. So Bill and Jackie, thank you so much again. That was an excellent presentation, and thank you to all the attendees who listened in today. We look forward to having you join us for future webinars. This concludes today's program. We hope you have a wonderful afternoon. Thank you.